It's my honor to talk to you about my work, my research on an intervention that I developed called Mindfulness-Oriented Recovery Enhancement. And this is a therapy that I developed by translating findings from basic behavioral science and neuroscience into a treatment for addiction, stress, and pain. So I want to begin with a story from my clinical practice because I think this will kind of pull everything together for you. So recently I was approached by a gentleman who was seeking help to deal with chronic pain and opioid-related issues. He had had a series of 5 failed back surgeries, and after each surgery he had received escalating doses of opioids. He knew he was taking too high of a dose. He knew he had a problem with opioids, but as he so poignantly stated to me, I just don't want to be in pain. So to understand how to help people like this, we need to understand the role that hedonic dysregulation plays in pain, pleasure, and addiction. In historical Western philosophy, pleasure and pain have been considered opposites on a hedonic balance, such that experiences of pain are thought to outweigh the experience of pleasure in everyday life. The duality and unity of pleasure and pain have been classical targets for contemplative practices and philosophies. Take this quote by Tibetan meditation master Virupa. But modern neurobiological science suggests that pleasure and pain actually are not opposites, but instead operate through a common emotional currency in the brain, mediated by the mesocorticolimbic dopamine system and the endogenous opioid system. And these neural circuits, which are involved in processing hedonic or pleasurable experience, are the same neural circuits that become hijacked by addictive drugs through an allostatic process in which increasing sensitization to drug-related reward comes to outweigh the experience of pleasure from natural rewards, from healthy objects and experiences in the social environment. So to understand the role that hedonic dysregulation plays in the downward spiral linking chronic pain to prescription opioid misuse, my colleagues and I developed the following theoretical model. So I'm just going to run you through it very briefly. So in brief, the recurrent experience of pain leads to attentional fixation or rumination on pain, which can result in negative emotions and stress. Then when patients take opioids, the opioids not only temporarily alleviate the pain, but they also alleviate the stress and negative emotions, at least temporarily. And then through the process of negative reinforcement conditioning, strengthen the opioid use habit, resulting in an opioid attentional bias or a hyperfixation of attention on opioid-related cues, like the sight of a pill bottle or when you're driving by a pharmacy, finding your attention involuntarily captured by those cues, which can drive opioid craving irrespective of the need to obtain pain relief. When this cycle recurs over and over again, it may result in neuroplastic changes to the brain, which can lead to hyperalgesia or an increased sensitivity to pain among some patients, as well as an insensitivity to natural reward, as we discussed earlier, resulting in opioid dose escalation as a means of obtaining hedonic equilibrium, and ultimately leading to the loss of control over opioid use that's characteristic of opioid addiction. So in my lab at C-MIIND, we measure hedonic dysregulation with a number of tasks from cognitive neuroscience. I'm going to tell you about one right now. The first one is called the dot probe test. And you ate your lunch, but it's been about an hour, so I'm not so worried about this next slide. So in the dot probe test, we have a computer screen and it's split in 2. On one side of the screen is a pain-related image. On the other is a neutral image. These images are presented for a very brief amount of time, either 200 milliseconds or 2,000 milliseconds, after which they disappear and are replaced by a dot. The participant's task is to choose the side with the dot. The dot shows up on the left-hand side of the screen, they hit the left arrow. If it shows up on the right-hand side of the screen, they hit the right arrow. The computer records reaction times. And it turns out there's a large body of research to show that chronic pain patients are faster to find the dot when it replaces the pain photograph than when it replaces the neutral photograph. And this provides an objective index of how much their attention is being captured by pain-related information. We also pair neutral images and naturally rewarding, pleasant images. And we pair opioid images and neutral images. And my lab was the first to demonstrate the presence of a prescription opioid attentional bias among chronic pain patients who misused opioids. And amazingly, we found that this prescription opioid attentional bias predicted whether patients were going to misuse opioids up to 20 weeks following the end of therapy. suggesting that opioid misusers exhibit sensitivity to drug-related cues. In my lab at C-MIIND with my good staff here, who I would like to recognize at the end of this talk, we also measure hedonic dysregulation with the emotion regulation task. In this task, participants are presented with emotional images, negative emotional images and positive emotional images. In response to the negative emotional images, they're asked to either simply pay attention to the image or to reappraise the meaning of that image, to reframe what's happening in the image as an opportunity perhaps for personal growth or a learning opportunity. So for example, with this mother and child crying, a reappraisal might be, the mother and child faced the tragedy together, but in doing so, it brought them closer as a family. Doing this can downregulate negative emotions. In contrast, when we present positive images, we ask patients to pay attention to them or to savor them, to mindfully focus attention on the image and notice positive emotions arising in response to the image and appreciate them, as well as any higher order affective meaning arising in response to the savoring experience. And during this task, we measure heart rate variability, which, if you're not familiar, is the beat-to-beat variation in heart rate controlled by the parasympathetic nervous system that's thought to be governed by a higher order brain network involving brain regions that help regulate attention and emotion. So recently, my colleagues and I published findings indicating that opioid misusing chronic pain patients showed significantly blunted heart rate variability during reappraisal of negative images, viewing positive images, and savoring positive images relative to chronic pain patients who took their opioids as prescribed by their doctor. We also found that opioid dose was significantly negatively correlated with positive emotion regulation efficacy. In other words, the patients who took the highest doses of opioids were the least able to increase their positive emotional response in response to the positive images, which is pretty sad, actually. And it suggests that opioid misusers exhibit insensitivity to natural reward and deficiencies in emotion regulation. So if this is the problem in this condition, what's the solution? So I developed mindfulness-oriented recovery enhancement as a means of tackling addiction, stress, and pain. And mindfulness-oriented recovery enhancement, or MORE, is an integrative therapy that unites complementary aspects of mindfulness training, third-wave cognitive behavioral therapy, and principles from positive psychology. MORE is a sequence treatment. It begins with a foundation of mindfulness training, including mindful breathing and body scan meditations, which from a cognitive neuroscience perspective are intended to strengthen capacities like attentional control and metacognitive awareness, which can then be applied to more complex therapeutic processes like reappraisal and savoring. So we build a foundation of mental stability and clarity through mindfulness. Then we apply the mental stability and clarity to helping people reframe the meaning of the stressors in their life and to savor natural pleasure. These therapeutic components are intended to modulate a series of therapeutic mechanisms and in turn produce stepwise change in a series of clinically relevant intervention targets. And today I'm going to be focusing on two such mechanisms: shifting from affective to sensory processing of pain and craving sensations, and restructuring of reward processing. So in MORE, patients are taught mindfulness as a means of shifting from affective to sensory processing of pain sensations. Chronic pain patients typically experience pain as a monolithic, solid, and unchanging entity, over which they lay a layer of suffering. They say to themselves, "Why me? This isn't fair. This pain is ruining my life." And that makes the pain worse. In MORE, patients are taught mindfulness to remove this emotional overlay and to decompose the pain experience into its subcomponent features. So rather than pay attention to pain as some terrible, awful, emotionally anguishing thing, we teach them to focus in on the sensations themselves. So perhaps pain is really a cluster of sensations of heat or tingling or tightness. We also teach patients to focus on the spaces in between the sensations where there's either no sensation at all or potentially positive sensations. And in doing so, this may make it easier to cope with the monolithic experience of pain as a whole. We call this zooming in. Similarly, in MORE, patients are taught the same mindfulness technique to cope with craving, breaking it down into its cognitive, emotional, and physiological sensations. Let's talk a moment about how Moore teaches patients to savor natural pleasure as a means of restructuring the hedonic dysregulation deficits that I talked about earlier. So in session 4 of the intervention, patients are asked to focus mindful attention on a bouquet of flowers, carefully paying attention to the pleasant colors, shapes, textures, and scents of the flowers, as well as a touch of the petals against their skin. Patients are guided to not only to focus on the positive sensory aspects of the experience, but to notice how the mind and body respond to the experience. And when positive emotions are noted, the patient cultivates a metacognitive form of awareness to then focus on and appreciate and absorb the positive emotions themselves. And this technique is intended to restructure reward, shifting valuation from drug-related reward to valuation of natural rewards as a means of reducing addictive behavior. And I call this the restructuring reward hypothesis. So if you're interested, I encourage you to read my theoretical paper in the Annals of the New York Academy of Sciences. So recently, I guess a couple of years ago now, it's not so recent, we completed a clinical trial of Moore as a treatment for chronic pain patients who were taking long-term prescription opioids. This was an NIH-funded stage 1 trial. We randomly assigned 115 chronic pain patients to receive either 8 weeks of Moore or 8 weeks of a process group. And nearly 3/4 of the sample reported misusing opioids. And not surprisingly, there were high rates of comorbidity in the sample, a lot of depression, anxiety, PTSD. In summary of the findings, we found that Moore led to significantly greater reductions in pain-related interference than the control group. And this effect was strengthened and maintained at 3 months follow-up. So pain interference measures how much pain is interfering with a person's general activity level, mood, walking ability, normal work, relationships with others, sleep, and enjoyment of life. We also found that Moore led to statistically significant yet modest reductions in pain intensity itself that were strengthened and maintained by the follow-up. With regard to the opioid-related outcomes, we found that Moore reduced opioid craving, even after we controlled for changes in pain severity. And we found that Moore reduced opioid misuse. There was a 68% reduction in opioid misuse in the Moore group compared to a 32% reduction in the control group, suggesting that this treatment really has therapeutic potential. To understand the mechanisms of the therapy, again, remember when I started this whole symposium, I'm not only interested in whether treatments work, but also how do they work. And the question how is important because it helps us understand how to make therapies better, how to optimize them. So to measure mechanisms, we use the dot probe task. And we found that Moore significantly decreased the pain attentional bias compared to the control group. People became less hyperfixated on pain-related information. We also found that among patients with an opioid attentional bias, Moore significantly reduced the opioid attentional bias. But we found some fascinating data in heart rate data collected during this task. So I don't think you need to know a lot about statistics to see that there's something big going on here. Essentially, what we found was that across all 3 Q conditions of the dot probe task, Moore was associated with significantly greater reductions in heart rate compared to the control group. But there was no difference in resting baseline heart rate, suggesting that these effects are not mere relaxation effects, but rather are specific to attention to emotional information. Moore seems to change the way people pay attention to emotional information. So to understand the clinical relevance of this, we asked patients to rate how aroused they felt by the photographs. And not surprisingly, decreases in heart rate in response to the opioid and the pain photographs was correlated with decreased arousal reports. They felt less triggered by those images. We found the opposite pattern in response to the pleasure photographs. Decreases in heart rate in response to the pleasure photographs were correlated with increased arousal reports, suggesting that Moore might increase physiological sensitivity to natural reward. We conducted a heart rate variability analysis and found that across the board, Moore was associated in significantly greater increases in heart rate variability than the control group, but that this effect was most pronounced to the pleasure cue condition in post-hoc testing. So who cares? What's the clinical relevance of this? And Susan was pushing us, what's the relevance of this work do rigorous science, but why does it matter to society? Well, here's why. We conducted a multivariate path analysis and found that the effects of more on reducing opioid craving were statistically mediated by changing heart rate response to pleasure cues, not by changing heart rate response to the opioid cues. In other words, more appears to reduce opioid craving by increasing physiological responsivity to natural pleasure, natural reward. And quite frankly, this was the most important finding of my entire career. I may not ever find anything bigger than this, to tell you the truth. Because it really suggests that the reversal of the allostatic process of addiction that leads to hedonic dysregulation is possible through mental training. And we found converging evidence in EEG data collected during the task. We found that more was associated in significantly greater increases in the late positive potential of the EEG in response to natural reward stimuli. And this increase in brain responsivity to natural reward was again correlated with reduced opioid craving, suggesting that more might reduce craving by enhancing physiological sensitivity to natural pleasure. And we also found converging evidence in ecological momentary assessments. So we asked people up to 4 times a day to report on their mood state and their pain level across the 8 weeks of the therapy. So this gives you a lot of data, 224 data points to be precise. And we found that across the treatment, more was associated in significantly greater reductions in pain from moment to moment. But it was also associated with significantly greater increases in positive emotions from moment to moment compared to the control group. In fact, the participants in more were 2.75 times more likely to be positively, affectively regulated, to be able to keep their mood in a positive state than people in the control group. Interestingly, decreases in pain were not associated with decreases in opioid misuse, but increases in positive emotions were. The patients who showed the largest increase in the trajectory of positive emotions showed the greatest reductions in opioid misuse. Again, suggesting that more may, in fact, restructure reward processing, increasing sensitivity to natural reward, which can come to outweigh drug reward, and thereby reduce addictive behavior. And we're finding converging evidence for this in fMRI pilot studies with smokers and psychophysiological research with obese people, looking at their responses to food cues. The same pattern. The more we teach people how to savor natural pleasure, to get joy from everyday experience, the less they're seeking it from unhealthy substances outside of themselves. So C-MIIND is interested in studying mindfulness-oriented recovery enhancement, but we also want to do really pragmatic work that can be easily implemented and disseminated throughout society. So I'm just going to really quickly tell you about an example of a study that I did with my colleague Yoshi Nakamura. So last year we conducted a study at the University of Utah Hospital with patients who were in intolerable, unmanageable pain. These are folks, writhing around in their hospital beds in pain from a variety of diseases, injuries, and surgeries. And what happened was when patients would report this pain level, they would get a flag in their medical chart. It would flag the social worker to approach the patient, and the social worker would ask the patient if they wanted to participate in a brief social work intervention. And if they said yes, they were randomly assigned to receive either 15 minutes of a scripted mindfulness intervention, 15 minutes of a hypnotic suggestion intervention that was also scripted, or 15 minutes of an education control condition. And we measured pain and related outcomes immediately before and immediately after the intervention. And what we found was pretty darn remarkable. 15 minutes of a brief scripted mindfulness intervention reduced acute pain intensity by 23%. Brief scripted hypnotic suggestion reduced pain by 29%. And pain coping education itself reduced pain by 9%. Across the people who received one of the 2 mind-body interventions, nearly a third of them achieved at least a 30% reduction in pain intensity, which is considered clinically significant. And it's also comparable to the amount of pain relief you would receive from taking 5 milligrams of oxycodone. Which makes me wonder, why aren't we doing this in every hospital and healthcare center in the country? 15 minutes. The people who do, I want to underscore, these were not MBSR instructors. This was an average hospital social worker who received 2 hours of training in how to deliver these interventions. Could alleviate the pain and suffering of people with really serious medical conditions. So it suggests to me that mind-body therapies may be cost-effective and feasible to implement in standard healthcare. So in conclusion, and I really thank you for your attention and sticking with me here, mind-body therapies like MORE are promising treatments for addiction, stress, and pain. MORE may ameliorate chronic opioid use and misuse by strengthening the hedonic regulation of pain, craving, and reward. And from a clinical standpoint, teaching patients to take in the good and mindfully savor natural, healthy pleasure may provide the learning signal needed to reverse addiction, which I know is a bold statement, but now we're engaged in a lot of pretty exciting studies to test this hypothesis further. And ultimately, techniques like MORE and other forms of mind-body therapies may reverse the downward spiral linking chronic pain to opioid misuse and stimulate an upward spiral of mindfulness to meaning. So thank you for your attention. We're holding the next clinical training in mindfulness-oriented recovery enhancement on September 16th and 17th. I really want to acknowledge my C-MIIND team, so could you guys please stand? My C-MIIND scientists and assistants, coordinators, thank you for all that you do. And thanks to all of you for your attention.